Welcome everyone. We are now live for our last day of our symposium. So it is day 4 of our 2024 McMaster Midwifery Research Center Symposium. We've decided on a 4-day format for this week because I think Fridays, especially when it's such a beautiful time of year during springtime, people don't really want to be on a webinar. So hopefully this 4-day format works for you, and we will be hoping to get some feedback from you at the end of the week as well. We are in a webinar format, so if you do have things that you'd like to add in terms of chat or questions, I would direct you to the Q&A box, which is at the bottom of your Zoom kind of dial or kind of bar, if you will. And you can type your questions in there, and we will have a chance to come to those when we get to it in the question period. Otherwise, I'd ask you to hold your questions until the speakers are done. When we have question period, you can also raise your hand and we can invite you to turn your mic on. So I'll remind you of that when we get to the question period. It is a very beautiful, lovely spring day here in Hamilton. And Hamilton is the traditional territory of the Haudenosaunee and Anishinaabe nations. And as the leaves are popping just in the last day, I feel like all of the leaves in my backyard have come out and the birds are singing. And I told people on Monday that there's actually a nest right outside my window. And today there's beautiful little bird chirps happening. And it's, I'm filled with a lot of gratitude and love this time of year and the spring and feeling connected to everything around me. So I also want to acknowledge my role as a guest on this land, and that my role is really in learning to take care and to take responsibility with the caretakers of this land to ensure sustenance and well-being for all, from all of us to the birds outside my window. And beyond just a feeling of gratitude, I'm also really committed to actively listening, learning, and unlearning, and really spending time with the narratives and deconstructing them, the ones that have shaped my understanding of this land and the people that are part of it. And that's active work I'm trying to do towards truth and reconciliation and the ongoing process of decolonization. And we've reflected on that through the week, particularly in relation to Red Dress Day being only a few days ago. So I'm mindful of that and carrying that with me today. So thank you everyone for joining us. We have had, I think, a fantastic week. It's been really great to see a variety of speakers and a variety of panel discussions, and I think we've covered a diverse amount of topics. All of the recordings from the symposium will be up on our website and our YouTube channel. You could always subscribe to our YouTube channel. But it takes us a little while to, do the final editing and presenting of that. So keep checking back in the weeks ahead, and you can direct any folks who are not able to attend to those videos as well. Today is our day to highlight some of the research being done at the MMRC. So we were supposed to have our first thesis student presenting their master through our McMaster master's program. She was going to present her thesis findings today, but unfortunately she's quite ill and has had to cancel. So Rebecca was going to share with us the experiences of midwifery-led medical abortion through Ontario's expanded midwifery models of care. And we are wishing her a speedy recovery at home. And we are going to see if it's possible to record her presentation separately and then still post that on our website for everyone to watch after the fact. So that means that we have a little bit more time today for our 2 other presentations. And I'm really pleased today that I'm joined by our 2 new scientists at the MMRC, Ginny Brunton and Karen Lawford. So I will give you a full bio and background on each of those folks when it's their turn, but welcome Karen and Ginny, and we're delighted to have you here and to be able to highlight all the amazing research that you're doing. Ginny is joined by Abigail Corbin for their presentation, and we can maybe, I will read your bios and give a little bit of background about each of you, and then we'll invite you to share your screen and we can head right into it. So Ginny Brunton, you have a long bio, Ginny, is RN.
Edit it.
Edit it. I'll just splice it down. Currently a member of the nursing faculty at Ontario Tech University in an associate professor role. Ginny's research interests come from clinical training and experience as both a nurse and a midwife in community settings and birth settings. Ginny's worked in Canada and the UK and has extensive background in research methodologies, specializing in systematic reviews used for research synthesis that bring together different types of research on effectiveness, implementation, and people's perspectives. Ginny's research focuses on the fit between health policy, health promotion, and public health issues, and community involvement in health interventions related to child health, teenage pregnancy, parenthood, women's experiences of becoming mothers, fathers' involvements in family, mental health outcomes, a whole variety of things. You're a busy person, Ginny, with lots of expertise, which is fantastic. And we're so glad to have you now as part of the MMRC. Let me see. And I think that's a good summary. Anything I've left out, Ginny, that you want to add?
Nope, that's great.
Beautiful. Okay, and Ginny is joined today by Abigail Corbin, who's the patient care manager at Canada's first alongside midwifery unit and the diabetes program at Oak Valley Health in Markham. Abigail is responsible for managing the adult and pediatric diabetes education programs, the hospitalist midwife team, and the midwifery-led postpartum programs, which includes an early discharge program and the family and baby clinic. As an experienced midwife with academic and research involvement, Abigail is also an instructor in the undergraduate and graduate midwifery programs at McMaster. She is driven by a passion to develop midwifery leadership and is currently conducting research on roles, barriers, and enablers for midwifery leaders. Abby is profoundly committed to collaborative innovation and is an engaged leader who's invested in mentoring and building communities of practice. Her research interests are in the evaluation of midwifery models of care, midwifery leadership, and risk management. So welcome, Ginny and Abigail. And I didn't actually say the title of your presentation, but you are going to be sharing with us today about implementing group postnatal care at Oak Valley Health AMU, the evidence and involvement for that. And I know lots of folks are really eager to hear all about that experience. So I will turn things over to you now and you can share your screen.
Great. Thanks for that, Beth. Thank you for that lovely introduction. I think the fact that mine is so long just means that I've been at this a long time, really. So thank you. And I'm so pleased to be part of MMRC. Bit of a dream come true for me. Okay, I will share my screen. Hopefully we'll be seeing that okay.
Yeah, and then if you, from the beginning.
From the beginning. There we go. And then I just have to change my display over.
You got it.
How's that?
Pro. Yeah, that's beautiful.
Wow, great. Fantastic. We're off to a great start here. Okay, so as Beth said, we're going to talk about implementing group postnatal care at Oak Valley Health's alongside midwifery unit at Markham-Stouffville Hospital, and about the research evidence and the stakeholder involvement, that interest holder involvement that we're undertaking as a part of that. You'll see Abigail and I are authors on this work. It's a fairly big project. There's also some undergrad students of mine, as well as Liz Darling, Laura Banfield, the librarian at McMaster University, Sam Kruger, who is at Oak Valley Health as well, and of course, Beth. So Beth, you did a fantastic land acknowledgement. I don't think I could add much more to that. I just want to mention that I'm coming to you from the lands of the Mississaugas of Scugog Island First Nation, which is covered under the Williams Treaties. And we're on the traditional territory of the Mississaugas, a branch of the Greater Anishinaabe Nation, including Algonquin, Ojibwe, Odawa, and Potawatomi. I hope that all of us can reflect on and renew our commitment to live and work in a good way with our Indigenous neighbors. So,
I'm gonna jump in.
No, we're okay. Yeah, Abby, it's all yours.
Thank you. And thank you also for the land acknowledgement. Ginny and I are close geographically, so we are also in the same place in terms of our treaty acknowledgement too. Thank you for that. I'm going to provide a bit of the context for why we did this study, and then at the end I'll jump in again and talk about next steps. I think that this partnership really highlights the importance of the MMRC in terms of the partnerships with programs in the community and how research can lead directly to program outcomes. So this started a couple of years ago when we recognized that the volumes of the AMU were not increasing and were in fact decreasing. The way the Alongside Midwifery unit is set up at Oak Valley Health in Markham is that practices bring, like midwives bring their patients or clients to the unit, and they're supported by a hospitalist midwife. So our volumes are entirely dependent on our community midwives. And unfortunately, during COVID, like many practices in Ontario, our practices were getting smaller and not bigger. And so as a result, our volumes are going down. We are a large unit, and the hospital was starting to question whether the size and the budget was actually reflective of the volumes and were justified. And so we had to really think strategically about how do we continue the future of the Alongside Midwifery unit, still being absolutely fiercely committed to our community midwives. I think that we are demonstrating that this structure is actually very helpful in terms of sustainability for our community midwife partners. But was there something else we could do in addition? And so what we did is, knowing that there's a lot more demand from midwives to come into expanded models, that if we did create something on the unit, that we could attract midwives to work in that model, as well as providing care for patients here on the unit. So we went to the ministry, and we were successful in getting some funding for a new program that our hospital has very descriptively called the Midwifery program. So that's what we're doing. And then just going back to our connection with MMRC, we had this opportunity right from the beginning to say, okay, how can we partner with our research, our research partners to structure this program in a way that's important to us. And what is important is that it's reflective of our community, and that it includes the community right from the beginning in the structure of the program. And so Ginny, Liz, and I and Sam had a conversation right from the start about what could this look like, and what does it mean to provide or to co-design a new program. And Ginny's suggestion was to start with a scoping review of group care, which is what we ended up doing, which we're going to describe today. Because if we look at where we're at, I'm going to go with the next slide.
Bear with me a sec.
No problem. If we look at, so just to go back, our plan is to do group care. This is the model that we decided right from the beginning might be a good idea for this new program. It hits on some important notes for us, and in particular, group postpartum program. And I want to acknowledge that we are not the first center in Ontario to do group postpartum care, and that there are already some midwifery practices and some family doctor midwifery teams that are doing this model. And so we are obviously are looking for those examples too, and really wanting to build on that. But why is postpartum care important? If we look at this time in families' lives, it's quite significant, and they are quite vulnerable at this point. So we know, as midwives, we know that postpartum care is a period of significant change. It's a huge transition, and people need to be supported through that. And how do we effectively support people in a way that's also financially responsible as well? And so trying to capture both of those. The piece for us at Oak Valley is trying to maximize volumes while maintaining really high standards of care. And where is that fine balance between the two? When we look at group postpartum care, there are some really good evidence-informed approaches. And so when we looked at the literature, what came out, and what Ginny will go into describe in more detail, is that there's a lot of individual studies on group care. A lot of them took place in lower income settings, and then higher and middle income settings, but we haven't really seen anything that tied the findings together, and that was a missing piece of the literature. So before we did anything, before we made any decisions in terms of what group care will look like at Oak Valley, we engaged in a scoping review. Yeah.
So in undertaking this project, I mean, we were guided by the midwifery model, because we're interested particularly, of course, optimizing normal biological, psychological, social, and cultural processes related to the postnatal period. prevention and management of complications. But importantly, respecting in people's individual circumstances and views about their lives and about their care, and working in partnership with those people to strengthen their own capabilities to care for themselves and their families. So that involvement piece of the midwifery model of care is really important, and that informed how we approach this project. And we are also interested in utilizing an integrated knowledge translation approach with this, because we can engage knowledge users in the research process more directly. And it's suited for research application and program implementation. So it seemed like a good way to help us to guide us in this project. So, of course, being a scientist, I have to take you through all the methods and results and discussion. So I'll tell you a little bit about how we did it and what we found, and then what we think the implications are for the Markham-Stouffville Hospital program. So in terms of the scoping review methods, we involved knowledge users. For the scoping review, it was midwifery practitioners, managers, and researchers getting together to collaborate with the research team on the protocol development, research question formation, determining study eligibility, interpreting the results, and the knowledge translation plan to share the findings from the scoping review. We started with, of course, a research question. We sought to understand the nature and extent of evidence that outlines the implementation, effectiveness, and appropriateness of group postnatal care, or GPNC, models. And to do this work, we employed a rapid scoping review design, and we used standard guidelines for that. So the PRISMA scoping review guidelines, and we also utilized the rapid review guidelines by both JBI and Cochrane Collaboration. So a scoping review aims to understand the nature of research available on a given topic, the research landscape, if you will. Rapid reviews use a simplified process to provide information to decision makers in a more timely way. The important thing about rapid approaches is that you are transparent about what you're doing. And so the rapid methods that we used for this particular scoping review, we applied them during the screening and data extraction phases only. In terms of searching and screening, we developed our search strategy in consultation with Laura Banfield, the McMaster Faculty of Health Sciences librarian. We searched Medline and CINAHL to date. We have not yet searched Embase, but we did say in our protocol that we're going to do it, so we're just working on finalizing that. And we also searched key websites and the reference list of included studies. In terms of screening, we did an initial calibration exercise between 3 researchers to get over 90% agreement on ratings. And once we achieved that, we basically divided up the screening and screened independently. It was a 2-stage screening process where we screened title and abstract and then screened full report. In terms of eligibility to be included in the analysis, studies had to focus on the provision of group postnatal care. They had to contain data on implementation, effectiveness, or appropriateness, be published in English or be translatable. And we did a deviation from the protocol that was in a good way. We screened studies published prior to 2000. Initially in the protocol, we said we were going to screen we weren't going to screen anything before 2000, but we ended up doing it anyway. To data extract information, we used an adapted version of the Tidier checklist, which looks at implementation. So we looked at study demographics, we looked at the characteristics of the studies in terms of their methods and their populations, the program characteristics, so the setting in which group postnatal care is implemented, the intervention characteristics, so what actually did group postnatal care look like, and then the implementation evaluations. So how was implementation evaluated in terms of acceptability, appropriateness, adoption, feasibility, penetration, fidelity, reach, sustainability. There's a lot of different ways to evaluate implementation. And then to analyze and synthesize all of that, we just looked at descriptive frequencies of all of the different data items that we extracted, and then ran narrative summaries according to SWIM guidelines. So the results from doing all of that, we identified 3,494 references in total. 109 of these were retrieved based on the title and abstract, and we were able to get 106 of those, which were screened on full text. Of those, 22 references met our eligibility criteria, and they represented 15 studies. So we included 15 studies in our analyses. Most studies were excluded because they didn't talk about comprehensive postnatal care. So physical assessment plus health education plus peer support. And then next, most often they were excluded because they focused on a particular health condition and didn't necessarily focus on health promotion or disease prevention generally. Briefly, study demographics. The majority of these interventions for group postnatal care, it's quite new. Most of them have been implemented within the last 10 years, and reports have been published within the last 5 years. So it is very new. And there's quite a range of countries in which group postnatal care has been implemented. You can see Canada right there in the middle that has had one published report of care in British Columbia, actually. So both high and low income settings, this is being implemented. In terms of the study characteristics, there's a range of studies that have quantitative, qualitative, or mixed methods used. And there are very diverse participant samples. Most often women are the participants in these studies, but there's also studies including group postnatal care providers, other healthcare providers from the wider multidisciplinary team, family members, partners, policymakers, community members, and so on. When you start looking at the program characteristics, there were studies that looked at group postnatal care as a standalone intervention. It was offered on its own in about half of the included studies, and the other half, it was combined with antenatal care. So it was more of a complete follow-through package. The majority of these group postnatal care programs were universally targeted. So in public health language, they're targeting to the wider population and not focusing on perhaps specific subgroups that are more vulnerable or marginalized. And full implementation is most often reported in these studies. So they've gone past the sort of adoption and development phase and feasibility testing to full implementation. When you look at the intervention characteristics, all of these studies had a group size of less than 15 people. Most of them were less than 10 people, so they're fairly small groups. The settings were primarily primary health clinics. And in terms of how it's actually offered, the onset range across the 15 studies went anywhere from being set up antenatally to being initialized at the 6-week postnatal visit date. The duration range could go anywhere from 6 weeks to over 1 year. In some cases, they went up to 3 years in length. The frequency range went anywhere from one single standalone session that happened postnatally up to 30 sessions. And the intensity was pretty consistent across all of the studies. They're generally around 1.5 to 2 hours in length. In terms of who provides it, it seems to be provided by 2 providers in each case that we looked at. Most often it was either midwives or nurses who were the primary provider. The second provider was, it ranged quite a bit, could be anybody from the multidisciplinary healthcare team. So you might have physicians, physiotherapists, doulas, social workers, project assistants, sometimes helped out, community health workers. So there's quite a range, but generally you had that core of either a midwife or a nurse who were the primary provider. And provider training was indicated in over half of the studies. although few provided details about what that provider training looked like. But they did talk about the importance of, you know, managing groups and managing conflict and having the content knowledge. So speaking of content knowledge, this is an example of the healthcare topics that were covered in one particular study. They focused on, and this is kind of indicative of what health education looked like across the 15 studies. So it was a mix of health assessment, education topics for women or for childbearing people and for infants. Also topics related to development for both of those clients, and safety issues as well. When you look at how the implementation was evaluated across these 15 studies, most often it was acceptability that was examined, followed next by sustainability, and then by reach. So that's kind of what the main findings of the review were. This is an important piece of work, I think, because it's the first available synthesis of this topic. Nobody has looked at this yet. It's such a new intervention that's being offered, and it's being offered increasingly in high-income countries like Canada, the US, the UK, and we did connect with researchers in the UK who are connected in with the group postnatal care 1000 project that is taking place in Europe right now. So we were able to get that connection. So although everybody's looking at it, nobody's brought it together into a scoping review. And we did identify more research than we anticipated. There's a lot of different models, different ways of doing it, different components to it, and it's offered to a fairly wide range of participants. It appears to be acceptable to providers and patients. And there's multiple factors that have been identified that might better support success and sustainability. Of course, because we used rapid methods, there's a potential for data loss or errors, but we did have minimal trade-offs using this rapid approach because we only utilized single reviewer screening for screening and data extraction, but our reviewer agreement was extremely high. In fact, it's the highest I've ever had in a review. So we had that going for us. So what can we take from these findings? When we're thinking about how do we get the findings from these studies into how we design a postnatal care program, a group postnatal care program for Oak Valley Health? We can look at the data around its value. So that's data that we pulled from studies that measured adoption, acceptability, appropriateness, and effectiveness, and the processes that we should consider when we're developing that group postnatal care program. And that data was provided from studies that evaluated reach, feasibility, penetration and fidelity, and sustainability. So embedding what's valued about group postnatal care into program design are things like making sure that we market the program appropriately. So we foster a culture of learning and we tailor it to clients' needs and explicitly foster peer support. We ensure a mix of participants in terms of parity, socioeconomic status, and ethnicity. We establish strong, safe communication links between members of the healthcare professional team for sharing client and program information so that clients can be assured that their data is safe or are safe. We can explore potential trial outcomes because this is a good opportunity to look at evaluating group postnatal care in a practice setting. So we could think about measuring social cohesion, social support, social isolation with our participants, and think about what kind of identified behaviors we want to see, and of course, healthcare utilization as potential trial outcomes. Obviously, all of that is going to be done in collaboration with our client partners. So how do we build strong program processes to make sure that this is successful? Consider the mode of delivery and the impact on attendance. Do we do it in person to start and then move to online later? Because some of the studies did offer virtual group postnatal care and there were issues around attendance. Consider the program frequency, timing, and duration, perhaps weekly for 1.5 hours, and then up to the first week, 6 weeks initially, and then expand. Establish early formative evaluations to communicate with wider knowledge users like clients, managers, healthcare professionals that are external to the program, and explore barriers to the program with non-attenders to understand why it is that people are invited to attend and then don't. And then think about marketing this as a population-wide initiative to ensure that everybody who could potentially attend understands it's for them. It's not for a specific subsection of the population, because there were some concerns about that. Establish regular meeting times and dates so that it's consistent and clients know that it's always going to happen on a Tuesday at 2 p.m., for example. Confirm administrative support. A lot of the studies talked about the importance of having appropriate project administrative support to make sure that, you know, bookings happened, that clients found the space, that health education materials were provided, that equipment was cleaned and available. And then establishing ongoing methods to evaluate fidelity and feasibility. So observation, chart audit, checklist, self-assessment. There's lots of ways you could monitor how well the program is doing. And then how do we make sure that it's sustainable and it continues over the long term? Of course, the first most obvious thing is to confirm ongoing funding. And I think we're lucky in that there is some committed funding for this. And hopefully we can demonstrate program success and it can continue. Ensure that there is initial and ongoing training for midwives so that they feel supported in being able to provide this and integrate it into the work that they're already doing. Liaise with Markham-Stouffville Hospital's marketing department to be able to target audiences appropriately. Ensure adequate administrative support is in place. That's a process thing, but that's also a sustainable thing. Utilize previous program clients. Some programs in the literature actually have graduates from the program come back and act as volunteers. So there's something to consider. And then most importantly, set up or utilize a transdisciplinary advisory group. So it includes clients, other healthcare practitioners and managers that are external to the program to advise on how the program runs, how it's evaluated, how it develops. So now I'll hand it over to Abby to talk a little bit about how we're going to take that forward with our clients.
Mm-hmm. As I'm reflecting, Ginny, during your presentation, I again just want to highlight the benefit of having the partnership with MMRC. As a patient care manager, I'll often come up with like what I think are brilliant ideas for research, but if there's no capacity, right? And so being able to have the research team partner with us means that we're able to do these things right from the beginning. And as we go through, it's a huge benefit. So I just want to highlight that. So our plan is really to use a co-design format for structuring the groups. We have actually begun the midwifery program. We had our first clinic day today. We're starting in a one-to-one, more traditional midwifery model while we increase the number of people in care. Once we're at a level where we can provide groups, then we're going to transition hopefully this fall. So the benefit of that is that we have the midwives here in-house and we can do that training for facilitation and everything before we begin. And we can involve those midwives in creating this co-design, these co-design sessions. And so we're planning in June to have two, a virtual one and an in-person one, where we bring in previous clients, both of obstetrics and of midwifery, because I think it's important to have both perspectives. The midwives that are part of this program, any other midwives that are part of the AMU. And we're going to have specific questions for them around the content and processes. You know, true co-design is like you start from scratch and you're like, build this beautiful future for us, and we can do that. In reality, we had to ask for funding for something, you know, particular. And so we had to have some structure already in place, but there's still so much opportunity to say, okay, when we think about, you know, for example, do you want to have a list of like scheduled topics, or is it really important to you that with a facilitator is just reflective of what's important to the group today? Is it important to you to have in-person only or virtual or hybrid? one of the things that stood out to me from your findings, Ginny, was about the length of postpartum care. And of course, midwives in Ontario, we have this end date of 6 to 8 weeks, and yet we also now have this huge gap in care for infants. And it's interesting that our funding for this program came from Ontario Health, and it was from a pediatric perspective where they recognize that midwives have the ability to step into these healthcare gaps in providing newborn and infant care. And so those kinds of questions I think are really important to bring in. Ontario Health are quite particular about ensuring that we track patient-reported outcome measures, but also patient-reported experience measures. And so that's also one of the focuses of these groups, and the ongoing evaluation is ensuring that we are listening to the people that are going through these and adapting the care that we provide to their needs as they evolve. And then just the last thing I want to highlight too is you talk about barriers to care. And we know that we're providing care in a hospital, and with that comes barriers and structures in terms of paying for parking and access. So how do we ensure that we provide low barrier care, and what does that look like is really important to us. I just want to highlight a conversation that I had with Jenna Bly, one of our midwives in Ontario, and Jenna talked about what is the midwifery model of whatever it is that we're talking about. And one of the values is low barrier care. And so how do we ensure that we continue to offer that in these new and innovative models? And then I just also wanted to highlight your point about administrative support. Historically, expanded midwifery care model funding has not come with administrative support, but this time we were able to negotiate through Ontario Health a little bit of clerical support, and that is really important. But it does add a whole other side of, how do you work with our admin team to ensure that the care we're providing is seamless, and it's been a learning curve for them too. So these are coming up in June. We're really excited to listen and to learn and to involve those in the structure of the care that we provide. And I'm just really excited to have ongoing partnership with Ginny and with MMRC in terms of evaluating and publishing the data, because if we're doing something here that is working, we want to be able to share that with other people. And I think midwifery research needs to grow, and we need to highlight the work that we're doing. And we couldn't do that without those partnerships. So thanks, Ginny.
Thank you. It's a great opportunity. References for those that are interested. And that kind of brings our presentation to a close. So I'd be pleased to entertain any questions or comments.
That's fantastic. Thank you so much, Abby and Ginny. That was really, it is such an important scoping review that you've done, because you're right. Lots of people are talking about group care. There have been, sites where it's been working effectively for a long time. But the evidence supporting it maybe hasn't been pulled together and summarized in a way that is useful for people. So that's really great. If folks have questions, I know Abigail might have to run. She's juggling lots of schedule things today, but I'm sure Ginny can field questions. So if people want to put anything in the chat in the Q&A box, or if you'd like to raise your hand, we could take about 5 minutes for questions.
I'd be curious to know if other people are looking at this model throughout the province and what they're planning to do. Because I just think the more we share information about this, the better the program can be.
Mm-hmm.
I think too, it's really important. I know Beth, you and Liz and I were talking about the importance of creating evaluation methods that we don't have to use just at one site, that we can use at multiple sites. So that as we are all doing these really amazing innovative ways of doing midwifery, that we also don't have to come up with our own ways to evaluate. And I think that's a huge area of need currently. We have a sudden explosion of expanded care models, and each of them are being asked by funders to say, okay, give us your KPIs, give us your metrics. But is there a way that we can work together to say, here's a really good patient-reported experience survey that you can use? And so actually we have a student midwife working with us on this project to come up with an experience survey that we can use. And then of course we would be really happy to share and to learn from other sites as well.
Yeah, I think it would be great to have an existing kind of toolkit we can share with the expanded model sites so that they can, adapt and modify. I think that's on our to-do list. What were you going to say, Ginny? And then there's and Pilar agrees an experience survey would be great.
I was just going to say it would be good to connect in with the core outcome sets for trials, just to make sure that we're capturing things that will be standardized, that it is possible for others to utilize and then subsequently integrate into future evidence synthesis. Sorry, got my systematic review hat on there.
Yeah, we love that. And I know Karen Lawford actually has a question for you too. So Karen, do you want to unmute and share your question?
Yeah, thank you. Wonderful presentation. I am really curious about if you came, and if my understanding was postpartum you were looking at specifically.
Yeah.
So did you ever run into literature that described prenatal education on reserves that was offered by the government of Canada, specifically FNIB, Health Canada?
No.
Okay, it was a long time ago when Dawn Walker, maybe somebody in the audience remembers her. She was really leading that, and one of the issues that came up was that there was the lack of privacy, the perceived lack of privacy, perhaps. Well, again, if people feel it's a lack of privacy, it is, that people expressed, and so it wasn't really, and it was something that came out of the United States. This idea, I wish I could remember it. Like now I'm really interested, but you did mention that some people were not interested in participating. You said some populations didn't realize it was for everybody. I think could you explain a little bit more of that? Because that to me is actually probably I really want to know more about that.
Okay. So that was a specific study, or maybe two studies that looked at provision of group postnatal care. And one of them in particular, the participants, it was about providing comprehensive care for HIV positive clients, postnatal clients and their babies. So they were receiving group postnatal care that was, comprehensive physical assessments, health education, and peer support. They were also getting HIV treatment at the same time. So it was kind of like one-stop shopping. And they were concerned in terms of privacy. So that's where that particular finding came from. They were worried that if more than just the midwives had access to their data, that people would find out, and there was a stigma associated with that. That was in a low and middle income country, so that there may have been something cultural as well attached to that. So, and then there was findings from another study that was targeted towards low income individuals, and they had a perception that group postnatal care was only offered to kind of the usual client base, right? The sort of white middle class, upper middle class participants. And so marketing, needs to be taken into consideration. How do you advertise this as something that's equitable and available for everybody? Attached to that were some concerns about, it's important to have the conversation with clients about who should be part of the group. Are you going to have it geographically based? Are you going to have it based on a culture? It's going to depend on what's important to that client group. So yeah, there's a lot of tricky conversations, and you raise a really good point. Like, I didn't search the Indigenous research databases. And so it might be worth having a look at that to see if there's data there that we could also integrate, because that perspective would be really important with that focus on community. Yeah, so thank you.
Amazing. This is great. I'm going to have to hold our questions there so we can move forward with our next presentation. But there are, thank you very much, Abby, and thank you so much, Ginny. There are some questions in the Q&A box. And so if you have a moment to look at them, you can always type an answer. But people are very excited to hear about this and happy that we're moving back to group programs, because with COVID, we didn't do that. And so it's nice to be able, especially in some of the expanded models programs, to really be able to bring people back together again.